Good evening. Welcome to the Screen at 23 in New York webinar. I'm Dr. Warren Chen, Executive Director of CAMS, the Chinese American Medical Society in New York. This webinar is sponsored by CAMS, Chinese American Medical Society, in cooperation with our partners in Asian American Health Equity, including Joslin Asian American Diabetes Initiative, Joslin ADI, National Council of Asian and Pacific Islander Physicians and Habbe, and American Diabetes Association, ADA, to talk about Screen at 23. We'll discuss how this impacts our patients, since 1 in 2 Asian Americans have prediabetes or diabetes. Half do not know their status. And Asian Americans are the least likely ethnic group to be screened for diabetes, but twice as likely to have diabetes compared to Caucasian Americans. Asian Americans continue to be underrepresented and even invisible in public health research, data, and policy, including type 2 diabetes screening. This has to change, and change can only occur if we can all work together and demand it from policymakers. There are already 6 states, Hawaii, California, Massachusetts, Illinois, Washington, Virginia, that have passed the resolution. We'll discuss what we can do here in New York. This session is being recorded and can be shared for future use. We have short presentations from a very distinguished composition of physicians, researchers, and public health experts. And then we want to go to open discussion with everyone. Each speaker, please give a brief description of yourself. Our first speaker will be Dr. Chang from Joslin ADI, and he will give us an overview of what is Screen at 23. Dr. King.
Thank you for the nice introduction. I am Dr. George King from the Joslin Diabetes Center. I'm head of research here. I've been professor of medicine at Harvard Medical School. I've been active in Asian American with diabetes since over 40 years. So I'm very excited that this Screen of 23 are going on across the country. So let me tell you a little bit about why this campaign is so important, and why for Asian Americans, the differences in weight is very unusual compared to other ethnic groups. May I have the first slide, please? So, good, thank you, very good. So this is the Screen at 23 logo, and it's supported by multiple organizations, as Asian American, Native Hawaiian, Pacific Islander Diabetes Coalition, the National Council of Asian Pacific Islander Physicians, American Diabetes Association, Center for Disease Control and Prevention. Next slide, please. Now, there are mainly 2 types of diabetes, although now there are perhaps 10 to 15 different types of diabetes. But in general, the type 1 is the common in children and usually autoimmune. They require insulin, and it's destruction of islet, and they have genetic related to the HLA genes. And but it's very rare in Asian Americans or Asians. Asians have 10 times lower type 1 diabetes than Caucasian populations. The type 2 diabetes is the most common one in Asian, as with other groups, but 95% of Asian Americans have type 2 diabetes, almost all in adults, associated with obesity, aging, and other factors. It's not insulin requiring, and it's insulin resistant. Now, the problem here is the obesity point, which is much different in Asian American than for others at risk for diabetes. Next slide, please. So this is the data actually from New York. I purposely picked this slide, which show that at the normal weight, I think I can't say too well, but it's less than BMI of 25. The Asian American in light blue has highest rate of diabetes than any other group. And if you keep going to the overweight, you can see that the non-Hispanic white and the Black population starting to increase as well. So for a white population with BMI of 30 is really the tipping point for developing type 2 diabetes. But for the Asians is a very low way of less than BMI of 25 already. Next slide, please. So to really accentuate what this difference as causing the poor diagnosis in Asian American, a coalition was formed for, as I mentioned before, and starting in the before 2010, and since then there have been at least 5 major accomplishments. We have organized many national meetings to advocate about diabetes in the Asian Americans, and with the help of many organizations, including the ADA and CAMS. We published 5 major papers about diabetes in AAs. We convinced the National Health and Nutrition Examination Survey to include AAs in 2011. And this is really, really key because this is the study that the country and the various agency for reimbursement use for deciding which item for healthcare they will fund. And Asian was never included until 2011, even though this study started in the early 1970s. So this was a major hurdle we had to overcome, and change it for criteria for screening of diabetes in the Asian Americans by many national organizations, including ADA and now CDC, AMA. And this is screening for diabetes at BMI of 23. That's why it was initiated as a national campaign called Screen at 23. Next slide, please. So this is what was referred to by Warren earlier, that the NHANG study have shown now 2011 to 2014 that the Asian Americans, which is the fourth double bar to from the left, that it's very high rate of diabetes, as shown in dark blue, but the green is the undiagnosed rate. So you could see that Asian American had one of the highest undiagnosed rate by the NHANG's early study, the first 4 years of study. Next slide, please. But there has been some improvement. So looking at the data from comparing 2011, 2014 to 2015 and 2018, as you can see that the diagnosed rate initially was 9.3, but unfortunately it's gone up 2015, 2018 to 11%. But the undiagnosed rate actually have decreased 6.5 to 5.3. So if you look at the bottom table, it says undiagnosed percent of total compared to early years, 41% to 33% now. So I think it has some improvement by increasing the knowledge about screening their early screening for diabetes at lower BMI. Next slide, please. So this is, I think, the last slide. That's as Warren mentioned that we want multiple states to pass resolution to screen for 23. So far, we have 6 states and 3 other, Oregon, Ohio, Maryland, are pending, and New York being one of the state that have one of the highest number of Asian American, clearly will be critical for the success of this effort. Next slide, please. So I think that's really it for my part of presentation. So I'm going to give the podium back to Warren for the next speaker.
Thank you, Dr. King. Our next speaker is Dr. Maria Rosario Habbe Araneta from the Department of Family Medicine and Public Health at UC San Diego. She will discuss science and history of screen at 23.
Good afternoon. I'm Habbe Araneta. I am the PI of the UC San Diego Filipino Health Study. I'm also the co-PI of the Diabetes Prevention and Outcomes Study. We're one of 26 sites in the country. I'm happy to talk about the science and history of screen at 23. Next slide, please. So we were invited by the American Diabetes Association to write a position statement to define the optimal BMI cut points for screening Asian Americans for type 2 diabetes. Next slide. And we're very pleased that since January of 2015, the guidelines have been changed. Previously, anyone who had a BMI greater than 25, who had any of the diabetes risk factors in the yellow box, were encouraged to be screened. And since 2015, the inclusion of Asian Americans with BMI greater than or equal to 23 has been included. Next slide. This paper, which was published in 2013, was based on data from Kaiser Northern California hospitals. California has the largest Asian American population, and also has the ability to disaggregate Asian American subgroups. So this paper shocked the medical community. Whenever I ask my medical students, name the 3 groups with the highest rates of diabetes, they always answer incorrectly. So these data show that Pacific Islanders, followed by Filipinos and South Asians, had the highest prevalence of type 2 diabetes, higher than groups that are typically perceived to be at highest risk, namely Latinos, African Americans, and Native Americans. And then each of the Asian subgroups also had higher diabetes prevalence compared to whites. Next slide, please. This slide shows the BMI and those individuals who did not have diabetes in black, those with newly diagnosed diabetes in gray, and those with prevalent diabetes in white. The orange line represents a BMI of 30. That's the definition for clinical obesity. And you'll notice among all the Asian subgroups, they all fall below that BMI of 30, below that obesity line. Next slide, please. Several imaging studies have shown that Asian Americans, and in this case, a South Asian gentleman with a beard, even though they have very low body mass index at 22.3, accumulate more body fat. And this difference in regional fat accumulation has been shown in Japanese, Chinese, Filipino, and Korean populations, where they seem to accumulate more visceral adipose tissue. Next slide, please. So our goals were to identify the optimal cut point to diagnose, to screen diabetes among Asian Americans over the age of 45. Next slide, please. There is no national study of Asian Americans in the United States. So we had to resort to 4 cohort studies, including the Filipino Health Study in San Diego, the North Kohala study in the island of Hawaii, which had a sizable Japanese and Hawaiian cohort, Japanese and Filipino cohort, and then the Masala study in San Francisco and Chicago, and then finally the Seattle Japanese Diabetes Community Study led by Dr. Fujimoto. The participants had to be over the ages of 45 without any prior diagnosis of type 2 diabetes, with concomitant measures of BMI, glycosylated hemoglobin, and a 2-hour oral glucose tolerance test. Next slide, please. So these were the criteria where we had to have demographic characteristics, age, sex, self-reported race, ethnicity, and then type 2 diabetes was defined by the ADA criteria. Next slide, please. What we found was a prevalence of about 17%, slightly higher among Filipinos because they were an older cohort, and about 13% among Japanese and South Asians. Next slide, please. This is the most important slide because it shows that if you look at people to the left of the yellow arrow, so if screening was limited just to a BMI of 25, you would miss all these newly diagnosed diabetics with a BMI as low as 16. This was someone who was 5'4", 94 pounds. And if she was not screened, she might have continued to have been misclassified as non-diabetic until she started to develop diabetes complications. So limiting screening to a BMI of 25 would miss 36%. With the old guidelines, you would miss one out of 3 Asian Americans with type 2 diabetes. Next slide, please. This shows the same thing. If we limited screening to a BMI of 25 and higher, we would miss 1/3, the 102 in the red font, who had diabetes but might not have been screened with the old BMI cut points. Next slide, please. We did a lot of fancy statistical tests and established that a BMI cut point of 23 or higher would be the optimum cut point to screen among Asian Americans. Next slide, please. So what are the implications? Among the 21 million Asian Americans, we estimate that about 500,000 are undiagnosed. Screening at 23 might identify 300,000 Asian Americans with type 2 diabetes. We would still miss about 200,000 with a BMI less than 23, such as the woman with a BMI of 16. Next slide, please. So these are newer data from Northern California, Kaiser. This were up to 2016, a year after the guidelines were shown. And what you see is an increase, but you still see similar trends where diabetes prevalence is highest among Pacific Islanders, Filipinos, South Asians, and higher among all of the Asian subgroups compared to whites. Next slide, please. And the next slide shows an update similar to what Dr. King presented, where you see when you look at Asians together, the proportion that are undiagnosed are about similar to Hispanics who are undiagnosed. What's important though is the disaggregation. When you disaggregate the Asians, you'll look at East Asians here, it's about 14%, similar to whites, and then higher among South Asians, mostly Asian Indian, and Southeast Asians who are mostly Filipino, and their rates are higher than Latinos. And so the value of disaggregating becomes very important. Next slide. Just wanted to acknowledge all of the funders for our collective studies for the 4 cohorts. Thank you.
Thank you. Very interesting data. Our next speaker schedule is Dr. Joslin from the Coalition of Asian American IPA in New York. Unfortunately, there's a conflict because it's their annual shareholder meeting tonight. So the data on diabetes in Chinese in New York City will be presented by the CAM's president, Dr. Victor Chang. Dr. Chang?
Hi everyone. My name is Victor Chang, and I'm glad to present these slides on behalf of Dr. George Liu, who is an endocrinologist and whose work, some of his data will be featured here on Chinese Americans in the New York City area. So we'd like to go over the prevalence of diabetes in the US and in the Chinese American community in New York City, differences in diabetic care between CAIPA members and the general population. So CAIPA has a multidisciplinary diabetes clinic that addresses all aspects of diabetes care, and what we can do to help with awareness, management, treatment, and prevention. Next slide, please. So we start with noticing that the prevalence of diabetes in China, type 2, has been increasing over the last 30 years, and paralleled by an increase in obesity and overweight. So the large 109 million in China, multiple environmental aspects, obesity, aging, diet, physical activity, and multiple genetic loci that can confer an increased risk of diabetes. Next slide, please. Paralleling the rise of diabetes in the United States, in China is the percentage of diabetes in the United States over the last 20 years, again, for similar reasons. Next slide. And we'd like to present some work, a study that looked at data on hemoglobin A1C that was accumulated by an HMO using values from the bioreference lab. These were all HMO Chinese members, and these were A1C levels from 2009 to 2015. So approximately 109,000 had one A1C test, and a total of 380,000 A1C tests were done. Next slide. So from looking at this, we have this is by age, we look at diabetes and normal. So we see that in patients with, on the left hand, the total number of samples, age greater than 65 and age 18 to 65, it would appear that the number of patients with diabetes is greater in the older age range. Next slide. If we further include information of patients with prediabetes, defined as a specific range of hemoglobin A1C values, and we look by age categories from left to right, we see that the number of prediabetes is actually a very high fraction, and that even in the 18 to 65, the middle bar is the highest of the three. The next slide. So this segregates A1C less than 5.7, the left column. The mid column is prediabetes, and the right column is patients with diabetes. So if you look by age groups, we see that at the bottom, with the age greater than 64, only 11% had a normal A1C level, and 55% were pre-diabetic, and 35% were diabetic. But then if we look at the 18 to 64 age range, we see that the fraction of pre-diabetics is again quite high at 52%, and the slightly greater number of normals at 32%. Next slide. If we then take that data and compare that with the general population, so we see for all our participants, the non-diabetic is higher for the general population. The pre-diabetic for the Chinese population is 45% versus 30% for the general population, and diabetes is the same for both groups at 18%. Next slide. Well, then additional data is from the Chinese Diabetes Prevention Program, which was a joint effort by the New York Presbyterian Hospital, KAIPA, City University of New York, and Pace University. And the study was to test the effects of this program that was culturally and linguistically tailored for use with Chinese immigrants. Next slide. So to try to gauge the effects of this, they looked at serial changes in A1C tests, and the first A1C had to be the pre-diabetic range. Next slide. Well, what they found was that they used a program which used weekly meetings and trainings with exercises and Tai Chi and yoga and nutrition and dietary teaching, that in the participant group, weight loss was minus 3.5% versus minus 0.1%, and changes in the hemoglobin A1C at month 12 was 3.8% in the participant group versus 0.1% in the control group, suggesting that in prediabetes patients, interventions can affect the outcome. Next slide. So this then compare this with the non-diabetic, non-Chinese or general population. If you look on, we have a summary in text on the left-hand side and a summary on the right-hand side by tables, that if we can see that the number of patients who improved was slightly greater for the patients. So 64% had improved, were in the pre-diabetic category, but 30% had reverted to the non-diabetic category, and 5.7% into diabetic category, whereas 11% of the general population went into the diabetic category, and 26% into the non-diabetic category. So there's a slight increase for the Chinese group in terms of becoming non-diabetics. Next slide. So this again is just a brief summary slide of data comparing Chinese and the general population. And I guess the point that strikes me the greatest is just a high number of pre-diabetic patients in the Chinese population compared to the general population. Next slide. So briefly to summarize then, on behalf of Dr. George Liu, the prevalence of diabetes, prediabetes, and obesity has been increasing in the United States. The percentage of pre-diabetic patients in New York City Chinese is greater than in the general population, especially in the 18 to 64-year-old group. And the intervention programs data suggests that a culturally tailored program of training, exercise, and diet can lead to better outcomes in the Chinese population. So those were the comments and slides that Dr. George Liu had prepared for tonight's meeting.
Thank you, Dr. Chang. This is good to know that intervention work. Our next speaker is Mr. Stephen Habbe from the American Diabetes Association, and he'll discuss what ADA can do and support the screen at 23 in New York. Mr.
Sure.
Habbe?
Thank you. My name is Stephen Habbe. I'm the Vice President of State Government Affairs for the American Diabetes Association. Just to share a little bit about our organization, we are the largest voluntary health association serving all people with diabetes, and our mission is to prevent and cure diabetes and improve the lives of all people affected by diabetes. I know we will have a different slide set that will be brought up momentarily. There we go. We serve at our organization serves in a number of capacity, funding research, delivering services. We provide objective and credible information, but I wanted to drive home just in terms of our advocacy work that we support government funding for research and prevention. We work to ensure affordable access to healthcare, medications, and technologies so people can manage their diabetes. We work to prevent type 2 diabetes, fight discrimination, and advocate for health equity. And that's why we're thrilled to partner with this on this initiative, the Screen at 23 initiative. Just to speak to that partnership, if we could move to the next slide, just to sort of recap some of the history here. Back in 2011, ADA and Joslin Diabetes Center partnered with the National Council of Asian Pacific Islander Physicians to organize a diabetes symposium in Hawaii. And that work led to the development of the Asian American Native Hawaiian Pacific Islander Diabetes Coalition. That's played an important role with the Screen at 23 initiative, as was described by the earlier speakers. ADA has provided guidance and support to that coalition, including funding the Screen at 23 campaign website and helping to support Screen at 23 legislative resolutions. And along the way, we changed our standards of medical care in diabetes to reflect the need to screen Asian Americans for type 2 diabetes at a BMI of 23. Speaking to those legislative resolutions, we could move to the next slide. We've supported resolutions, and it's great to see the successes that have happened over the years with these legislative resolutions to foster awareness about the need to screen at 23 in a number of states. And we look forward to working to get a legislative resolution also passed in New York. We know that that's critical, particularly when we think about the number of people that are at risk in New York. We earlier heard some data around New York City. If we can move to the next slide, just wanted to share some overall information around diabetes in New York. Nearly 11% of the adult population have diagnosed diabetes, and every year over 100,000 people are diagnosed with diabetes. But we still have that large group of people, about 450,000, that have undiagnosed diabetes that we need to reach, including many members of the Asian American community. And of course, we have that much larger contingent of people, over 5 million people in New York, or a third of the adult population, are pre-diabetes. And as was shared, the prevalence of pre-diabetes is higher in the Asian American community. So all the more important that these efforts to screen move forward so that we can identify people who have diabetes and ensure that people get connected with the care they need to prevent complications. And if they're identified to have pre-diabetes, so that they can take those efforts, either the ones described or other programs that exist to help people reduce the risk for going on to develop type 2 diabetes. I did also just want to share in the next slide, we work in a number of ways at the American Diabetes Association to address various health equity issues. And we came out with a list of a Bill of Rights spotlighting 10 areas for improvements. And I just wanted to highlight 2 of them, because ultimately, if we can screen people for type 2 diabetes, we then are in the position to ensure that they are getting connected to what they need for diabetes management, the issue highlighted here in the third bullet. And on the next page, we also then are in the position to help people that have pre-diabetes to stop that from progressing on to type 2 diabetes. So ultimately, the screening just plays a critical role in being able to address these two key dynamics to addressing diabetes in New York. So I appreciate everyone's interest today and hearing more about the Screen at 23 initiative. It's certainly very important. And thank you for having me join the presentation. Thank you.
Thank you, Mr. Habbe. Our next speaker is Mr. David Hawk from NCAPIT. He will discuss a campaign for Screen at 23. I know that David, along with Dr. Ho Chang and Dr. Winston Wong from NCAPIT, has been working for this for a long, long time. David?
Thank you, Dr. Chin. And quick, Joanna, can I share my screen? I think my presentation's probably changed a little bit. Let me do that here. And let me know if this works. Sorry, last minute updates. Okay, everybody can see the slides? Good. Okay, well, thanks to CAMS and all of our speakers and everyone in the audience tonight. I am David Lee Hawks, and I have coordinated the Screen at 23 campaign since 2016 and been working with the AA and HPI Diabetes Coalition and in NCAPIT for over 10 years now. It's been a while. So a reminder, we're here to address Screen at 23 in New York and also Asian American invisibility. So I'd like to take it back to whom are we serving? And this picture is a representation, an example of Asian Americans who might be at risk of diabetes and prediabetes. So we know that half of the Asian Americans, roughly, with type 2 diabetes are undiagnosed and unaware, and that screening at a lower BMI of 23 helps a lot. And you've heard from some of the organizations, but internationally and nationally, this is supported. It's supported by the evidence that Dr. Araneta, Dr. King, and Dr. Chang shared. And this campaign has been in effect for 3 years. We wanted something simple that stuck in the brain, screening at 23, doing what it says, we've been able to drive 6 state resolutions that established a legislative baseline to direct their departments of public health to promote this information and really get the word out. But all of these efforts were driven by local champions. And that's why we're going to need you in the audience from CAMS and others to help and partner in this work, raising awareness of Screen at 23 in New York. And it's not only doctors, but trusted messengers from all backgrounds and advocates. Again, whom are we serving? These are people and families that we're ultimately trying to reach. On the right-hand side, that's a snapshot of a Screen at 23 resource. It's just a BMI calculator, but it's available in Asian languages, and we have a lot more resources for patients as well as physicians. And those resources, I will share a link shortly for that. So Stephen Habbe shared, and thank you, Stephen, and the ADA for your partnership on this over a number of years and help with all of these resolutions. Keep in mind, every state resolution included local champions, included folks who were connected oftentimes with the departments of public health or leaders in those areas among the legislatures and the ADA. So if we break down who the state resolutions impact, we're talking about over 100,000 Asian Americans who wouldn't have been diagnosed without the Screen at 23 criteria, not to mention the many, many more with prediabetes. And as all of you know, prediabetes is a stage where you can really intervene and prevent diabetes from happening. And as Dr. Chang shared on behalf of Dr. Liu, we're talking about very disparate numbers and big numbers in New York among Asian Americans, Chinese Americans included. These are just snapshots of the resolutions that were passed. And there has been broad bipartisan support for all of these in every state. And we have a resolution actually drafted for New York. We're talking about 31,000 cases plus of diabetes, many more of prediabetes, and we want to get this passed in 2023. We're going to need your help. So what can you do? One thing you can do is identify folks in your network. That includes physicians and non-physicians, individuals and organizations that serve the Asian American community, that treat Asian American patients, that are interested in health equity. This includes your local representatives. Ultimately, we approach these folks that this is an educational and awareness building drive that is dealing with an important health disparity. Getting in touch with those partners and reps and sharing information, we're going to make it easy. So after this webinar, within the next day or so, we'll share ways to do that. We'll help with sign-on letters and providing information to you. So be on the lookout for that. And if you want to go the extra mile, you can get in touch with us too. That's my email, as well as Chihiro Sato from Joslin AADI. If you have ideas, we're more than happy to share. As I said, this has been a community effort and will continue to be so. Every person's ideas and energy matter. And the Screen at 23 campaign link has all the resources we've accumulated over the last several years that I mentioned. When we talk about Asian American invisibility, these are things that probably a lot of you all are familiar with. Things like, we're too small to be counted. There's no data, especially disaggregated data, on us. We're put in the other category, not to mention various stereotypes. And sometimes we end up as an asterisk at the bottom of the page of a guideline or a paper. So while Screen at 23 tackles diabetes disparities in Asian Americans importantly, it also touches upon this broader issue of Asian American invisibility in public health and equity. I want to end with a quote that I'll read. We cannot divorce Screen at 23 from the argument that Asian Americans are often invisible in public health equity. Our populations should be seen, counted, and our inequities addressed. And that comes from Dr. Winston Wong, who just so happens to be our next speaker. So thanks everyone, and thanks to CAMS Jamie Love, and Joanna Lee, and I am finished.
Thank you, David. Thank you for laying out the pathway of what we can all do. Mr. Hawk said, our next speaker is Dr. Winston Wong from Habbe. He'll discuss health equity in screening and diagnosing type 2 diabetes in Asian Americans. Dr. Wong, please.
Well, thank you, David. I've never seen myself quoted, but I also want to thank Dr. Chen and Dr. Chang for really championing this effort. CAMS has been part of the National Council of Asian Pacific Islander Physicians in terms of our partnership for many years. And we stand together in terms of this effort, among other things. I just wanted to mention that the National Council of Asian Pacific Islander Physicians was started about 13 years ago, and it's really meant to provide a national voice for these issues, as well as advocacy around coverage and expansion of insurance for underserved populations, and also making sure that the voices of leaders in the Asian Pacific Islander and Native Hawaiian medical community are really elevated to make sure that our issues as a community are well noted, as well as the fact that we have some work to do in terms of recognition, in terms of our contributions to American medicine. I don't have any slides, but now in retrospect, I wish I did, because I could show you the nice logo of the National Council of Asian Pacific Islander Physicians. But having said that, I did want to speak directly to the audience here, because, as I reflect on the work that has been shared by our champions and diabetologists like Dr. King and the researchers like Dr. Araneta, one thing that comes to mind is that the science has been indisputable. The data that has been shown to you with regards to populations of South Asians, East Asians, Southeast Asians, Pacific Islanders, Native Hawaiians, all that has been looked at very carefully. And I do also appreciate Dr. Liu's presentation with regards to the particularities of New York State. It's indisputable that we are underdiagnosing diabetes and prediabetes to the detriment of the Asian American, Pacific Islander, and Native Hawaiian population. Now, having said that, what has changed? And I shared this thought a few months ago. What has changed is obviously COVID-19. And as you noted, probably as clinicians in New York State, we had pockets of disproportionate mortality and morbidity of Asian Americans in the state of New York, as well as other parts of the country. And one could argue that many of those people that died or had serious disease actually had chronic disease that was not diagnosed at the very beginning, and to be noted that they were at added risk for the consequences of COVID-19. It is really an indictment of the fact that we have not been able to see and identify people that were at risk for the consequences of infection of COVID-19. The other aspect, and I know New York is at the epicenter of this, is the rise of Asian American Pacific Islander hate. And I don't need to go through all the data that show that there's been 2 to 3 times increase of hate incidents for Asian Americans and Pacific Islanders, but it is, and it underscores the fact that we continue to be perceived as perpetual foreigners and or as agents of disease and undeserving of recognition as citizens and residents of the United States. So it is not much of an extension to say that our fight for Screen at 23 is really this fight for recognition as full members of this country and full members deserving the kind of access and diagnosis and clinical care as any other person who lives in the United States. So I think that's an important aspect of how we look at this particular campaign. It really is a reflection of the commitment of you as the frontline physicians who care for this community, and the commitment of policymakers with regards to not ignoring an issue that is potentially decimating many of our elders in our communities. It's also, I think, a rejection of the persistent invisibility, as I mentioned before, of AAPI needs. We need to say that we will not sit to see that these AAPI needs, particularly in diabetes, be neglected. And I do think too that policies and actions like Screen at 23 give us as physicians the ability to exercise our political voice and become much more influential in terms of what our policymakers need to be responding to. We need to be able to amplify our voice and be able to show up with regards to why these issues are a public health consequence. So I just want to agitate for the fact that beyond the science, beyond being good clinicians, we need to be stewards of our community and to think about how we can really push agendas like this forward. A resolution is just part of the puzzle. The other parts are making sure that our communities are aware and that our medical physician colleagues are aware and the healthcare system is on notice that they're not going to ignore the needs of our community. So thank you for this audience and for sharing your thoughts with us in the next question and answer period.
Thank you, Dr. Wong. I like the quote that you had. Just going through looking some data, 5.6% of US populations are Asians. It's 8.35% of New York State populations are Asian. And New York State is the second state with the most Chinese populations. So we got to do this. And Dr. Victor Chang from CAMS will discuss next, what is the next step that we do for Screen at 23 in New York. Dr. Chang?
Now, well, I think the Chinese American Medical Society and myself strongly support Screen at 23 effort. It has great potential for improving health outcomes for all Asian Americans with targeted interventions for pre-diabetic and diabetic patients. The kind of steps we have are very similar to what David Hawkes had outlined, contacting our fellow colleagues and friends to let them know about this effort, contacting our representatives, and to participate in sign-out lists and other ways to let everyone know about it. So I would suggest that you look forward to receiving some more information in the next few days about additional steps. That's all I have to say right now. But we'll be looking forward to working with all of you in furthering this effort.
At this point, we are open to questions. There was a question that was in the box, but I don't see it now. But let me start out, ask a simple question. The data from China says using BMI 23 to 27.5 for overweight and over 27.5 for obesity. Do we accept this data in US for Asian Americans?
Habbe, can you, that's in your special area, can you answer that?
Could you repeat the question again, please? I know it had to do with you.
Yeah, the data from China that I think Dr. Lu's presentation showed that in China, they define overweight as 23 to 27.5 and obesity as over 27.5. Are we accepting this criteria in US for Asians?
I think the important thing to consider is not so much attaching a label as far as what cut point defines somebody as overweight or obese, but the numbers are consistent. So if the definition there is BMI of 23 or higher as being overweight, it's consistent with the BMI of 23 cut point that we use here.
Yeah, thank you. Any other questions from the audience?
I think there was a question that was put on the chat line with regards to some of the dialogue that's occurring in organized medicine right now with regards to whether race-based algorithms are legitimate. And this has come up with regards to looking at estimated GFR as pertains to Black Americans. And some of the criticism has been, if you look at the evidence base for GFR adjusted with a coefficient for Black Americans, it's been shown potentially to be population discriminatory with regards to Black Americans, that a good proportion of Black Americans have perhaps not been diagnosed for renal disease earlier on because they were given maybe a misleading GFR based upon a Black coefficient. Thus, some authors are claiming that it's important to get rid of race-based algorithms. And this is an important topic that medicine needs to address. I will say that there was an article that pointed out the deficiencies of an estimated GFR for Black Americans and tried to include the question of screening at 23 for diabetes for Asian American patients as being potentially as dangerous as having an estimated GFR for Black Americans. So I think between what we just heard from the scientific data that was presented, there's a danger of conflating a lot of issues with regards to what the importance of race is, what the importance of genomic pools are, and what we know of population studies. And I would say the screen at 23 is so critical for a population-based approach to making sure that we capture much more accurately and early the individuals with diabetes and pre-diabetes. No clinical decision-making should be automatically made for any individual just upon, non-thinking of clinical circumstances, but we do need population-based guidelines given that people come in and see us every day and that we have some expectations with regards to how our healthcare system is able to accommodate people from various walks of life.
Thank you. I was told there's a question by Karen Chu that raised a hand, but I don't see it on the box. Can she type in the question? While we're waiting, I have a question for Mr. David Cox. And we reach out to camps in New York. How can you coordinate the other ethnic medical group in New York to work with us together to bring this resolution?
The question is how to work with other groups. Yeah, good question. We see this as the first of many webinars, and there's obviously a very diverse, sorry, one second, there's a jet overhead. That's what happens when you live in Virginia Beach. We're going to be working with South Asian medical groups, as well as every group that we can. And I think we want to do a webinar that specializes on each group, bring in speakers that represent both physician and non-physician leaders in the community on this issue, and then bring all of these groups together for a sustained effort in 2023 to pass a resolution, and then also to really kind of get the grassroots of Asian American health equity folks together in New York and abroad. And we definitely feel like if we pass this in New York, the rest of the country will follow. Thank you.
I do want to, unless there's another question, I don't see it, but I do want to follow up on what Winston said earlier on whether using BMI like this on a specific group will cause racial issues or problems. I think that's a very important answer Winston gave, because I was just at another meeting two, 3 weeks ago, and one of the speakers literally said BMI should not be used for any medical studies or medical judgment because it's just inaccurate. In many ways, that is true, because BMI it has a lot of faults and deficiencies for many of the physiologies, studies for insulin actions and so forth. However, the problem is that we don't really have much else to substitute it. And we could say, let's screen everybody. If we screen everybody, then obviously we will be able to pick up diabetes and diagnose and pre-diabetes on everybody, but that is a huge effort. So this is really a effort for Screen 23, is pick up people who are the most vulnerable and need the most help, so we could help those individuals as fast as possible. Otherwise, if you wait for to be screened by everyone, that may take a while. So that's the reason for that.
Thank you. Are there more questions in the audience? Let's see. There's a question, a comment that we should look for correlations of waist circumference. Have someone comment on that?
I can. So in our cohort, we actually measured visceral adipose tissue through computed tomography, and that was a superior estimate compared to BMI, which is very crude. However, how often are CT measures offered during a clinic visit? They're very costly, and the risk of radiation exposure. So, but was waist circumference a good substitute? It was better than BMI, especially the waist-hip ratio. In fact, that's being considered in some Asian countries. So I've never had my waist measured during a clinic visit, and there are different ways to measure waistline. Some people just go like above the iliac crest or at the navel. So it would be a good option if it's done correctly and consistently, and would be different for men and women. BMI is crude, but convenient for now.
Thank you. Are there any more questions in the audience?
There is one in the chat about recommendations on how to educate or advocate with attending preceptors if one is a resident or medical student in primary care. And I think, for example, these are guidelines that have been supported by the American Diabetes Association. So we could certainly present those in discussing with attendings as a basis for this kind of practice. There's a question about issues with getting reimbursement or for needy patients to pay for some labs such as A1C and lipid panels on patients who have a BMI that's over 23. So that's a good practical question. I don't have an answer right now, and I think it may depend a little bit on the specific situation that you have in the clinic, and perhaps we can do some problem solving on a specific basis.
Well, you know, Victor, I just take a stab at that. I'm not teaching medical students right now, but I will say this. That's part of the reason why a resolution is important, because I think armed with a certain amount of codification, as well as the sound evidence that's disseminated and socialized, a preceptor would have a hard time saying that's not an appropriate test. Mm-hmm. If the evidence in the population-based studies suggests it is an important test. So it really shouldn't be an argument, so to speak, between clinicians. It should be, what's the standard of practice for a population that's at risk? And that would be the basis in which one could really rationalize why a more aggressive testing in any kind of clinical circumstance would be needed.
But also the glucose measurements are reimbursed for annual medical checkup. But Stephen, do you know whether A1C is actually reimbursed at the annual medical checkups?
I don't know if that's the case or not.
But we need to find out. That's a very important question.
Any more questions in the audience or in the chat? Let me see. There's a question on the chat. What's happening with screen at 23 in all the states between California and New York, even though the percentage of APIs are low? Who wants to take a step at that?
I kind of answered it in the text box. I want to emphasize how close we were to an Ohio joint resolution pre-pandemic, and I think that effort will resume, although we're concentrating on New York right now. Also, I want to take the opportunity to again give a shout out to Jamie Love of CAMS, who really put this webinar together and is working with us. Jamie, if you wanted to put your camera on real quick and say hi.
Hi, everyone. We're happy to help with this initiative. We are working with Habbe and Joslin Diabetes Center.
She's frozen.
Am I frozen?
Yeah, you're frozen.
Oh, but can you hear me?
Yes, I can hear you. Okay, now that's good.
Okay, so we are putting together a newsletter, and I am putting the link to sign up in the chat.
We can't hear you now, so cannot hear you. Maybe Victor, you want to?
Okay.
Let's give it a minute. Maybe they can get the Zoom to thaw out, and for Jamie to try talking again.
Can you hear me now?
Yes. Okay.
Okay. So very quickly, we're putting together a newsletter to give updates and information out on the screen at 23 for New York. I've put the link in the chat. We will sign up anyone interested.
I think you're gone again.
So Jamie, maybe you type it in the chat.
Well, maybe David, do you know what she's going to say?
I think Jenny she's shared a sign up for the we're going to reach out to everybody who's on the webinar, and that link is also a sign up link for anybody who wasn't able to join. So please pass that on. We're really going to get in touch in the next couple of days with an action item. We're not going to spam anybody on this list. That's not what we're here for. Everything's going to be actionable and specific right now to Screen at 23 in New York. And Luhu asked the question, is there an effort to raise awareness among clinicians? My PCP is an Asian American in New York who has never heard of Screen at 23. That's actually one of the main audiences we're trying to reach, the primary care physicians and clinicians who are doing the screenings. So I'm going to put the resource link from Joslin, and that has some resources specific to clinicians.
This physician must never come to any camp seminar.
Well, I think New York is going to be so critical because you are, as one of the largest population of Asian Americans, and at various meetings I go to in New Jersey, Connecticut. So when I bring this up recently, and the first question they ask us, well, what's New York doing? So I think this New York, once we get New York to pass the resolution, we can have many other states to encourage them to do it as well.
Absolutely, New York has to do it because we're such a huge Asian population, so many undiagnosed pre-diabetic and diabetic. So absolutely, New York has to do it. Okay. If there are not any more questions, I'm going to close out. I want to thank our esteemed panels for their excellent presentations and very insightful questions from the audience tonight. Like everyone mentioned, there's a lot of work that we need to do, and let's all work together to pass this resolution in New York State. We need your help. We need everyone's help. Like I said, New York has the second largest Asian population, we have to do this. This will make a difference for Asian Americans in New York. I especially want to thank Dr. Victor Chang, our camp's president, for spearheading this in New York. I want to thank Joslin API and then Habbe, who have been working very hard for Screen at 23 for a long time that I can remember working with them. So for future communication, please contact CAMS, contact Jamie Love, Joanne Lee at CAMS. So I want to thank everyone tonight and good night, everyone.